Hello everyone, my name is Heidi Christensen and I am a professor of spoken language technologies at the University of Sheffield. Thank you so much to this year's BCS Lovelace Colloquium organisers for inviting me. I've been following the colloquium for several years now. We hosted it back in Sheffield a couple of years ago and we are actually going to be hosting it again next year. But I'm really pleased to have been given the opportunity to talk a little bit about my research to this year's participants. I hope you've been enjoying it all so far. Unfortunately, I'm on annual leave when the actual questions and answering session takes place. So instead you're going to have the opportunity to meet two of my excellent PhD students who will be able to talk about their work that I'll cover a little bit in my talk as well and answer any questions you have. And if you've got any additional questions, feel free to send me an email. So let's move on to the slides. So I'm going to talk about using speech analytics and AI to detect dementia in a person's speech and language. And I've been working in this area, sort of the application of speech and audio technologies to healthcare for probably about the best part of 10 years now. And I'm really interested in the speech signal because there's so much we can learn from a person's speech. So of course we use speech to communicate with other humans. And increasingly with machines. So these days you've got automatic speech recognition on your mobile phones, sometimes on television, PlayStations, in your car, just about everywhere. So it's becoming a really pervasive technology that's with us everywhere. Lots of us have got personal assistants in the house, Alexa systems, etc. That will sort of have conversations and take actions from us as well. So to me, the speech signal is the most interesting signal that the human body admits. It's incredibly complex. It requires a lot of engineering skills to really work with it well, and a lot of knowledge, not just about from the engineering side, but from phonetics, linguistic side as well. And there's so much we can tell from it. So of course there's the linguistic message, the actual words that's being said, but there's so much more information that is in a spoken signal that you wouldn't have in text. And that extra information is to do with a person's physical and mental well-being. So we can tell a lot by listening to a person's, the way they're speaking, not just the words they're saying. So there's this notion of having linguistic and paralinguistic information in a person's speech, so we can tell something about their emotional state, they're happy, angry, disappointed, etc. So it's really easy for the human brain to pick up and tune into. A little bit more complex to get the computer to do the same. We can tell a lot about a person's mood, whether they're depressed, have anxiety, or stressed. Some of this is really easy for us to pick up as a human, but some of it we can use computers to really help us unpick these really tiny cues in the speech. And in general, it can tell us actually a lot about medical conditions that are affecting the brain, because of course it's the brain that generates the speech signal and the message. Things like tumours, Parkinson's disease, stroke, dementia, cerebral palsy. These are all things that have in one way or the other affects the speech signal. And so that's where a lot of my research is, to how do we use computers to detect these conditions and help and treat people that have these conditions to live as good a life as they possibly can. So let's look at just an example of what's in a message. So you might have a very simple question like, how are things? And you might get an answer back along the lines of fine, to which you might respond great. So this is a super simple conversation. Now let's imagine it's me asking my teenage daughter, how are things? So I'm maybe trying to convey this in a very neutral voice, how are things? And my teenage daughter might go fine, to which I'll go great. But she might also go fine, to which I'll go great. And so there's a lot of extra information in the way she's sort of pronouncing fine. It might mean fine, but don't ask anything more, or I'm not really fine. Or she might fine, you know, almost with a smiley face, so a lot of smile in her, positivity in her voice, and to which I'll say great. So lots of things to convey that's in the speech signal. And of course I've put these little emojis or exclamation marks here because of course when we are communicating just with text, we sometimes feel like we need to add in little extra science to really make sure people don't misunderstand how what we're really meaning. So what we would normally use the voice to do. So what if we ask the computer to ask a question, in particular something perhaps asking the brain to work a little bit hard, a memory-provoking question. So I might ask the computer to ask a person, perhaps a person who has been experiencing some memory problems. I might ask them, what did you have for dinner tonight? Sorry, what did you have for dinner last night? So let's imagine I'm asking you all this. I suspect, even though you are a lot younger than me, you'll have to just pause for a second and think what you had for dinner last night. I certainly need to do that, but it will come to you pretty quickly. So you'll be able to answer what you had for dinner. If I ask the same of a person with dementia or cognitive impairment in general, basically they may struggle to answer this, even with a little bit of pause for thinking, because you need to sort of just remember what you had for dinner. They may not be able to answer, or they might just take a little bit longer to answer than typical people, normal people without memory problems. They might use more vague words or empty phrases, so they might say things like chicken, I think I had chicken, or meat or something, because they probably have meat or chicken maybe every night, or they might say pasta or something like this, or so they're not being very specific about what they had. And they might also in general have a lot less expressive speech. And these sort of patterns and many more of them is what we can ask the computers to really help us try and detect. So this is what my team and I are looking for when we're looking at speech coming from people with dementia versus speech coming from people with no cognitive problems. So we're going to look at some of the research we've done on detecting dementia. I just wanted to describe in detail what it is. So it's a word that we often know. It actually describes a collection of symptoms. It's what's called an umbrella term. And so there's lots of different diseases that might cause dementia or cause this sort of collection of symptoms. And one of the biggest cause is Alzheimer's disease, which I'm sure you've heard about. So 70% of dementia cases is to do with Alzheimer's disease. And it is, with the Asian population in the world, becoming a huge problem, not just in the UK, but across the world. And it's on the rise. It is actually in England and Wales at the moment the biggest killer. So it is more causes more loss of life than, for example, heart disease, etc., and cancer. In terms of the cause, obviously there's a lot of research going into this, but we don't know for sure. There is no single cause, but there are a lot of known risk factors. Age is one. Genetics, so you could have an hereditary sort of disposition for having dementia. Smoking, so lots of kind of lifestyle choices. So smoking is not good. Having a poor diet is not good if it's the sort of diet affecting your vascular health. Not getting enough exercise is not good either. In general, kind of poor vascular health. So for example, if you've had a stroke, you are at high risk of developing dementia. And also it affects more women, which is not good news for all of us here, not least because of the hormonal changes happening around menopause. So these are all problematic things, and it's definitely a high a sort of priority in terms of research in the UK. It doesn't get as much money or emphasis as, for example, something like cancer. But just about everyone I meet will know someone in their family who's had dementia. So how does it affect a person's speech and language? So in this slide here, I've got lots of different things that starts to go wrong. So dementia is a kind of degenerative disease. So you can't get cured, and you get more and more poorly over time. So your actual speech is affected, your articulatory movement, so this is the physiological aspects of speaking are affected. Your larynx, for example, is affected. The way you express rhythm and stress and prosody, so the melody of your speech is affected. In terms of the language, so your ability to connect words and use the right words, so these are affected as well. Your ability to use unique words. You've got a smaller vocabulary size, using less informative units. If you are living in a country where you're speaking not your mother tongue, so like me, for example, who grew up in Denmark, you might, as you get older and get dementia, revert back to your mother tongue and forget your new language, even if you've lived here for decades. In general, word finding problems is one of the most common reasons why people go to the doctor, because they feel like something isn't quite what it used to be. In terms of conversation, and that's where a lot of my research has looked at, people are able to have a conversation on the surface of it, so answering questions, etc. But sometimes they start having difficulties understanding what's being said. They might repeat themselves a lot without being aware. So quite often all of us might sort of feel like, oh, I might have told this story before, but we will always sort of acknowledge it. People with dementia, they don't remember that they said it before, and so they again and again will tell, for example, the same facts. They might struggle to keep focused, and they might use more empty speech or vague kind of phrases. So these are all things that we're trying to look at. How can we use computers and signal processing and machine learning to really pick this up? So what's the motivation behind this? There are many of them, of course. In general, early detection means better treatment. Unfortunately, for something like dementia, you can't cure it yet. We're hoping this will change, but you can take medication to reduce some of the symptoms. So it's definitely worth knowing early. It's worth knowing as well for the family, so they can adjust the way they interact with you as well. If we're able to have an automatic system that people perhaps could use from home on a laptop or on a tablet or maybe on their mobile phone, it means that we can keep an eye on them over time. So it's very expensive for the NHS and for people as well to go and see the doctor. It takes time, it's a bit inconvenient, it's very stressful, especially for old people. If they could be at home, sit on a sofa, have a chat perhaps with a nice virtual agent, there might be a much better way of just keeping an eye on them, and so when it looks like they're definitely deteriorating, they could then be called in to see the GP or the doctor, neurologist. And so in general, having access to an easy to use and kind of low cost assessment means less anxiety for the patient and for their carers, their spouses, etc., and just overall a better patient experience. So this is what the NHS is all about, really trying to make life better for the people there. So a slide just describing, if you like, the engineering signal processing side of things, computer science side of things. So this is a very traditional pipeline that we set up for classifying speech that may or may not have come from a person with dementia. So in the top left, you've got the conversation with the patient, or the speech recording from them going into the system. You then need to do a bit of audio segmentation, finding out who's speaking when, if there's more than one person in the conversation, and also where sentences start and stop, or in general. And then you pass this on to an automatic speech recognition system. Sorry, that's my calendar warning me. So you pass this on to an automatic speech recognizer, which will then basically spit out a string of words that's been said. This won't be accurate. Occasionally there are mistakes, as you will know yourself from using speech recognizers, but it's pretty accurate these days. Although we have to do a lot of work to really adapt the speech recognizer to work for people with old voices, or perhaps people who are speaking in this slightly non-standard way because they are struggling with or they experience symptoms of dementia. And then once you've done the worked out what words has been said, you pass this on to what I've here called this speech pattern extraction. So this is looking for these little cues in the speech to do with all of the things we talked about: pausing, what type of words I'm using, the prosody in my speech, all of these things. So it could be hundreds of different little cues we're extracting here, little features we're extracting from the speech. And then all of this is passed on to the classifier, which has been trained to try and look for these different patterns, and will then spit out a probability of that particular conversation or recording coming from someone with a particular diagnostic category. And in terms of the classification, you probably know this, but you typically have a training phase where you learn labeled examples of audio with a known diagnostic label, and then you've got a testing phase or an evaluation phase, not phrase, sorry, where you infer some of the unseen data. So what we've been looking at, we got inspired by the doctors basically telling us that in those initial 5-10 minute history-taking conversation they have in clinic with the patient, they could actually tell pretty accurately whether that person would go on to be diagnosed as dementia. So just the way they are able to answer these very simple questions. And so we took this and initially looked at whether we could do this automatically based on recordings of their conversations with a human doctor, and then eventually replacing the human doctor with a digital doctor and avatar, and set up a system for using the recordings from there. And so you recognize this pipeline here with the speech coming in and the classifications coming out. So we are analysing, or we've set up this system called CognoSpeak that we're looking at commercialising and hopefully putting in the hands of doctors and patients in the not too distant future. So this analysing conversation between patients and this computerised talking head. And what we're initially doing is just helping the GP assess whether this patient who've come to see them because they've got memory problems are at low, intermediate or high risk of dementia. If they are at low risk, we're happy. If they're intermediate or high risk, they will be passed on for referral to the secondary care. But this means already a reduction in the number of people who are seen by the doctors in secondary care who really turn out not to have dementia. And so again, this is freeing up some of the neurologist's times and also freeing up costs, of course. So one of the things we ask the people when they do this test is to describe a picture. And so my PhD student, Elin Pan, who has almost finished her PhD, she's submitted and is due to have her viva soon. She's been looking for 3 years and a bit at what you can do with the recordings of people who describe a picture. So this picture here, called the cookie theft picture, is a very classical picture that is used. It is also, with my ED&I hat on, not particularly politically astute, so we've got a very traditional, stereotypical gender kind of reference. But leaving that aside, we're asking people to describe what they see in a picture and looking at what words they use and what connections they make. So, for example, people with dementia might often fail to connect the children with the woman and sort of not realise that she's probably their mum. Mm-hmm. And so they won't mention this. And so this test currently is used in clinic. And so the people who are administering the test then has to record and write down a lot, or manually kind of make notes about what's being said and in which way. This takes a lot of time. So there's a lot of motivation for trying to do this automatically. And what Elin did was to try and look at how clinicians do that. So there's been a lot of work using very engineering computer science methods, but she was really interested in looking at what, in addition, are the human neurophysiologist, neuropsychologist doing that we could add in here. And so she got interested in looking at the different hierarchical levels, if you like, of information that is being used, and thought about the word level kind of decline that you might observe. You see here in the Alzheimer's disease transcript of what's been said, they're using very generic terms like man and lady as opposed to boy and mother. And so we would spot this as a sort of decline, but also at the sentence levels, where there's sort of, and this person here sort of repeatedly sort of having doubts about whether they've said this before, and they're sort of repeating the same sentence more than once. Again, something that we would hope our algorithms would pick up. And so she set up this neural network, which I'm not going to go into with details, but it basically tries to replicate the processing that happens at these three levels: the word, the sentence, and the paragraph level. And she looked at using attention layers, which is this particular sort of quite modern way of finishing off a neural network, if you like, that would help us really pick out particular words that the neural network through time learnt was of particular interest. So things like mother and cookie jar came out when she analysed this. And so the results was that both this attention layer and this whole hierarchy improved the scores, and that stage achieved state-of-the-art results, which means that she had the best results out there on this standardized data set. So that was excellent. And the other student that you will meet at the question and answer is Meg Thomas. So she has recently started with me, and she has come in with a linguistic background. So we're trying to make good use of that and her knowledge from that side of things. So she's really interested in when more than one thing affects your speech. So, for example, people with depression, or rather the other way around, people with cognitive impairment, such as dementia or mild cognitive impairment, which is a precursor, often also have depression. So there's these two things affects the voice, and so if you're using, for example, speech-based systems like we've developed in my group, then it can be a little bit difficult to unpick what is to do with the depression affecting your speech and what is to do with the dementia. And so she's interested in looking at other additional things or cues we could be looking at, and she's particularly interested in disfluencies, which are present in speech of people with both MCI and people with depression. So she's sort of at the early stages. She's spent an awful lot of time annotating data, which is going to be incredibly valuable. So no one had done this before, so she's looked through and listened through all of our recordings so far and used her linguistic background to really find out what is there in terms of disfluencies. And of course, normally if you're doing speech recognition, you want to get rid of disfluencies because they're sort of slightly distracting to the overall linguistic message. But she's really looking at what can it tell us about that person and that person's kind of cognitive state. And the final thing I just wanted to cover that, of course, something like this that we develop in the Western world has worldwide applications. So a couple of years ago, before COVID, we went to Kenya with the digital doctor, the CognoSpeak system, and we looked at how we might be able to collaborate with them, record some people there, and basically set them up with having a system like this to assist them. And the particular situation in the developing world is, of course, that increasingly, especially middle class and upper class people, also live to an old age. So, they will have access to good medical care, and so they also get in their 80s and 90s some places, and of course then you also get dementia. But in those countries there are very, very few neurologists, for example, to help out. So in Kenya, the life expectancy is actually 63 years, which is pretty good because, of course, that includes infancy death and early age death. And it's gone up a lot, as you can see here, but they really have hardly any diagnostic expertise. They've got 17 neurologists to cover all of Kenya. I think I've, in my local hospital, got probably 17 neurologists to cover all of Sheffield. So they desperately need automatic technologies like what we are developing that you perhaps could use on a mobile phone. And so we looked at how we could collaborate with them and understand the particular issues in that country. And that is all I've got time for today. This is my big team that I should thank with all of this, without whom I couldn't do any of this work. And I just wanted to mention one opportunity. So in Sheffield, we are very fortunate to have what's called a Centre for Doctoral Training in Speech and Language Technology. So I supervise several students from there, including Meg, as you'll see on this picture here. So this is really well-funded PhDs that comes with a big program of upskilling. So if you come in with a linguistic degree, like for example Meg, you can get a lot of machine learning and computer training. And if you come in with a computer science background, like you folks will be, we give you a lot of training on linguistics, physiology, phonology, etc. So if this is of interest, have a look at our web pages, and in particular we've got an annual conference coming up where you can see talks from experts from across the world and from our current students. So we've got 3 cohorts so far, and it's free, so do consider that. And that's all I've got time for today. I'm just going to click back to my full picture, I think. Thank you so much for joining us, and enjoy the rest of the colloquium.